بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the lecture number 5 in the series of diagnostic radiology in English, titled or referred to by the letters DRE. And in this lecture we are going to handle the issue of the diagnosis of intracranial cysts. I hope you remember that we have exposed the issues of the normal brain anatomy, the cerebrovascular lesions, the brain tumors, the intracranial calcification, and now we are handling the intracranial cysts. And as you all know that intracranial cysts are mainly divided into extraaxial cysts occurring outside the brain parenchyma and intraaxial cysts occurring inside the brain parenchyma, and other cystic lesions which are not actually a true cysts, but they contain a cystic component, or they appear like the cystic structures in the CT or MRI images. Extraaxial cysts include the arachnoid cyst, epidermoid, the dermoid, and the pineal cysts. The intraaxial cysts include the cystic astrocytomas, the cystic types of astrocytomas, the hydatid cyst, and the porencephalic cyst. Then the colloid cyst is one of the intracranial cysts with special characters. We'll talk about it. Then other cystic lesions occurring intracranially will include the abscesses, the cysticercosis, leptomeningeal cysts, cystic deposits, and the meningioma with a cystic component. We'll start by the most famous intracranial extraaxial cyst, which is the arachnoid cyst. It has an incidence about 1% of all intracranial masses. And this cyst has a predilection for the region of the sylvian fissure or against the greater wing of the sphenoid anterior to the inferior part of the temporal lobe. Also, it can occur at the cerebellopontine angle, occurring in the retrocerebellar area in the region of the cisterna magna, as well as in the suprasellar area, and it can occur also inside the ventricle. Then these are the CT images showing the typical appearance and typical location of the arachnoid cyst in the temporal area in the region of the sylvian fissure. Being an arachnoid cyst containing CSF, it should show CSF density on CT images and CSF signal on MRI images. It will not show any enhancement in both CT and MRI. No calcium occur in this particular type of cysts, and being a benign lesion, long-standing cyst, it may cause some sort of bone remodeling, especially in the region of the greater wing of the sphenoid. Then intracystic vessels, I will just mention it in a moment. Look at this typical appearance of an arachnoid cyst in the inferior part of the temporal against the temporal lobe and posterior to the greater wing of the sphenoid. And you can easily appreciate the degree of bone remodeling of the greater wing of the sphenoid being relatively thin and bowing anteriorly, encroaching on the orbital cavity compared to the normal greater wing of the sphenoid on the opposite side. Then this is the appearance of an arachnoid cyst by MRI, T1 weighted image low signal, T2 weighted image high signal, exactly or almost exactly similar to the CSF in the ventricles. Then this is what we call intracystic vessels, because this is a cystic lesion and it occurs near the region of the sylvian fissure where the branches of the middle cerebral artery are present. Then these vessels will cross the surface of the cyst, and in the cross-sectional imaging they may appear as if they are inside the cyst itself. But intracystic vessels is not an issue but this represents the impression of the middle cerebral artery branches on the surface of the arachnoid cyst. An arachnoid cyst may be bilateral, may be symmetric or asymmetric. In the MRI, it will show CSF signal, also no enhancement, no calcification, and you have already know what about the intracystic vessels. Then this is the typical location of the arachnoid cyst against the greater wing of the sphenoid anterior to the temporal lobe. Arachnoid cyst in a typical location in a T1 weighted image sagittal image showing the characteristic CSF signal. The arachnoid cyst can occur anywhere, as I have said, in the cerebellopontine angle, retrocerebellar, and so. And also it can occur in the quadrigeminal cistern, and this is an example, a cyst which is occurring in the quadrigeminal cistern and is extending outside the cistern into the posterior parietal region. This is arachnoid cyst. Then we came to the epidermoid cyst, which represents about 2% of brain masses, of intracranial masses. It has a characteristic location at the cerebellopontine angle region, but can occur in the suprasellar or parasellar region in the middle cranial fossa, as well as in the cisterna magna, and also it can occur inside the ventricle. This cyst has a characteristic hypodense appearance on the CT, and on MRI it will have a low signal in the T1 and a high signal in the T2. Then one of the characters of this epidermoid cyst is the lobulated surface. The surface of the arachnoid cyst is smooth, but the surface of the epidermoid cyst is characteristically lobulated, as you can see, and this cyst in particular may show some mural calcification. Then by MRI, the cyst will show low signal in the T1, high signal in the T2, and in the flare, whenever you inject contrast media, the cyst will not enhance, as similar to the arachnoid cyst. But there is a great difference between the epidermoid and the arachnoid cyst, especially in the flare images. In the flare image, the arachnoid cyst will show the same CSF signal being because its content are actually CSF. But in the epidermoid cyst, the epidermoid cyst will not show CSF signal in the flare image. It will appear somewhat brighter than the CSF. Then this is one of the differences between the arachnoid and the epidermoid cysts. And the second difference is in the diffusion weighted images. In the diffusion images, the epidermoid cyst will show restricted diffusion, but the arachnoid cyst will show free diffusion. And this is epidermoid cyst in the suprasellar area extending into the sylvian cistern, and it has the characteristic lobulated appearance. In this CT image it shows hypodense texture. In the flare image it does not show CSF, typical CSF signal, and in the diffusion image it will show restricted diffusion, as you can see. Then in the flare image, epidermoid cyst will show intermediate signal. In the diffusion images, it will show restricted diffusion. Calcification can occur in this particular type of cyst, but it also shows no enhancement as similar to the arachnoid cyst. This is an epidermoid cyst in a classic location, the cerebellopontine angle. In the T1 weighted image post contrast, you can see no enhancement. In the T2 weighted image and in the flare image, it shows heterogeneous intermediate signal, which is not similar to that of the CSF. Then we came to the third lesion, which is the dermoid. And the dermoid cyst, its typical location is in the midline, either in the posterior fossa or supratentorial area, and also it can occur in intraventricular. Then this is relatively rare cyst compared to the epidermoid, and for the diagnosis of dermoid cyst we should have the fat density and the calcification. Fat is essential for the diagnosis of dermoid cyst. Then if you look to this CT image and you see a lesion which is almost in the midline, It shows a marked hypodensity here representing fat, soft tissue density, as well as mural calcification. And this cyst has a characteristic behavior, as it may rupture in the subarachnoid space and produce fat globules within the ventricles and within the subarachnoid space as well. And look at this CT image showing a fat density in the right side of this supracellular area. Then you can compare this hypodensity by the hypodensity of CSF, and you can realize that this is more dark than the CSF. And in the MRI T1 weighted image, you can see the brightness of the fat as similar to the fat in the orbit, and this is dermoid cyst. And whenever you are diagnosing dermoid cyst intracranial, you should look for the ventricles and the subarachnoid CSF spaces for fat globules. This is T1 and T2 weighted images of dermoid cyst not in a typical location, but you can see the fat within the cyst and other soft tissue structures, and you know that the sensitivity of MRI for detection of calcium is less than that of the CT, and that's why you can see fat very clear by MRI, but you cannot see calcium in most of the cases. Then this is in dermoid cyst in the subfrontal area, and you can see the fat signal in the T1 weighted image and also in the T2 weighted images. Then this is the dermoid cyst in the supracellular area. By CT you can see fat, and you can also appreciate the calcium. On MRI T1 weighted image, you can see the cyst, the fat shows bright signal, other tissues will show intermediate signals. A very important finding is the presence of high signal fat globules within the quadrigeminal cistern, within the sylvian fissure, and within some of the cortical sulci. This is an important issue, especially in the exams. Whenever you are confronted by a dermoid cyst, and you should look in the ventricles, and you should look in the subarachnoid space, especially look carefully in the CT images, because the difference between the fat density and the CSF is relatively low by CT, but it's very high by MRI. And you can see this is the dermoid cyst in the supracerebellar area. It contains fat, it contains other soft tissues, it contains foci of calcification. And if you look carefully here, you can see the hypodensity of fat within the ventricles compared to the hypodensity of the CSF, and also in the subarachnoid spaces. But this is much more clear in the MR image, and you can see fat of high signal, the CSF is of low signal in this T1 weighted image, and you can see also the fat globules within the subarachnoid CSF space. Then we came to the pineal cyst, which is this cyst is in most of the cases an incidental finding. It is usually found in the post-mortem cases, and this is the incidence. It's very high incidence actually in autopsy specimen. This cyst is usually small, is located in the region of the pineal body within the quadrigeminal cistern. It is usually asymptomatic, but if it is large, it may cause some headache, and it may obstruct the aqueduct of Sylvius or the posterior part of the third ventricle, producing hydrocephalus. The cyst usually contains fluid, and this fluid shows low signal in the T1 and high signal in the T2. If you inject contrast media, the cyst will not enhance. Then this is the cystic midline lesion in the quadrigeminal cistern, usually found incidentally, especially if it is small. It will show CSF density on CT, and it has an almost CSF signal on MRI. If you inject the contrast media, then no enhancement will be seen. Then one of the famous intraaxial cysts is the hydatid cyst, which represents 2% of intracranial space occupying lesions. And this system may be unilocular or multilocular. It can be multiple. It may show CSF density with no surrounding edema, no enhancement, but it may also show calcification inside. Then this is one of the most typical appearances of the hydatid cyst on imaging, and you can see a large cyst contains multiple daughter cysts arranged on the inner wall of the cyst itself. And you should remember that the hydatid cyst has a very thin wall and it does not show contrast enhancement. Hydatid cyst may be multiple, like this case, and you see multiple cystic lesions in the hyperparietal area of the left cerebral hemisphere, showing no marginal enhancement and no calcification. Borencephalic cyst is, by definition, is a cystic lesion which is communicating with the ventricle. It may be primary and may be secondary. The secondary type usually occurs after damage of the brain tissue because of ischemia, because of trauma, because of surgery, because of infection, and this damage will result in an area of encephalomalacia. And this encephalomalacia will result in dilatation of the ipsilateral ventricle because of the loss of volume of the dead brain tissue. Then the ventricle may communicate with the area of encephalomalacia, and you got what is known as borencephalic cyst. Then the colloid cyst, this is the incidence, 2% of all glial neoplasms. It has the characteristic site in the midline along the anterior part of the third ventricle, intimately related to the region of the foramina of Monro. And this cyst will appear hyperdense on the CT scan, and it will not show any enhancement after injection of contrast. The contents are hyperdense because of the viscid mucoid material, some blood elements, cholesterol crystals, CSF, and various ions. But you should remember that the colloid cyst is diagnosed by its typical location, not its density or signal characteristics. Commonly, the colloid cyst will show hyperdensity on the CT scan and high signal in T1 and high signal in T2 weighted images. But consider that the colloid cyst may show T1 hyperintense or hypointense, T2 hyperintense or hypointense. And in all conditions, this cyst will not show any contrast enhancement. Then we should mention these intracranial lesions which may appear like cysts or have a cystic component like the abscesses, the cysticercosis, and some of the intracranial tumors. And the abscess will be discussed in full details in the issue or in the lecture of the intracranial infection. And you know that the abscess looks like a cyst, but if you inject contrast media, the wall of the abscess will enhance uniformly, and the abscess being an inflammatory lesion, it will be surrounded by significant perifocal brain edema. And then this is the typical appearance of cysticercosis intracranial. It's small cyst with an internal hyperdense dot represents the scolex of the parasite, and this finding, which is typical for neurocysticercosis, is known as a cyst with central dot sign. Then we'll discuss also cysticercosis in full detail whenever we are talking about intracranial infection. This is parasitic infection resulting in multiple cyst-like structures. Then you remember from the lecture of brain tumors, we have mentioned something about the meningioma with a cystic component. And the meningioma is an homogeneously enhancing lesion based to the dura, and sometimes it may have a cystic component which is capping the tumor itself. Then you also remember the pilocytic astrocytoma, which is a cyst with an enhancing mural nodule, commonly located in the posterior fossa, usually in the pediatric age group, and it has this very characteristic appearance of a cystic component with an enhancing mural nodule. And also you remember the pleomorphic xanthoastrocytoma, or the BXA, with a cyst with an enhancing mural nodule occurring supratentorial. and the mural nodule should have a superficial location on the surface of the brain, either the lateral surface or the medial surface. Being intimately related to the meninges, it may show a meningeal tail, and the nodule, remember this, should be superficially located. Then cystic metastasis can occur from sometimes on primaries like the breast cancer and so. Then this patient with breast carcinoma has this cystic lesion with marginal enhancement and the mural nodule surrounded by significant perifocal brain edema. Then you consider the possibility of cystic metastasis. Then one of the cysts occurring intracranially is the pharyngeal duct cyst, which is known thoracic cleft cyst, and this cyst will result from persistence of the craniopharyngeal duct, which connects the nasopharynx to the floor of the cell. Then the cyst is particularly occurring inside the cella, and it may extend in the supracellular area. This issue will be discussed in full details in the lecture of the cella, and this lesion characteristically does not enhance, and if it can show some enhancement only of its wall, but solid enhancement of this lesion do not occur. Then one of the cystic lesions also intracranially is the craniopharyngioma, especially the adamantinomatous type, with characteristic cystic component, solid component, and calcification. And this will be also discussed in full details in the lecture of the cella. And I thank you very much.